Good morning. I'm Brian Edwards, Chief of External Communications for the American College of Surgeons. I'm pleased to welcome you here today to our news conference about the importance of using blood to help injured patients prior to their arrival at the hospital. We have a fantastic panel here today, and we organized this with the American College of Surgeons Committee on Trauma, which is really the preeminent voice and the preeminent experts in the field of trauma in the United States and around the world. And so we are very fortunate to have a fantastic panel discussion today. This is live online, so we invite questions from our media. You can email questions in at pressinquiry@facs.org. That's pressinquiry@facs.org. Or you can add your questions to the chat on the YouTube. The recording of this session will be available approximately an hour after this event, so about 1 p.m. Pacific Standard Time. So I'm pleased to welcome and turn this event over to our moderator, the chair of the Committee on Trauma for the American College of Surgeons, Dr. Jeffrey Kirby, who will moderate today's session. Dr. Kirby?
Great, thank you. Thank you, Brian. I really appreciate the introduction and the opportunity to come together to talk about a topic that's so very important to many of us. We have an opportunity to save thousands of lives a year with a single intervention, pre-hospital blood. Uniform access of blood can have a major impact on outcomes for our trauma patients. Trauma is the leading cause of death for patients aged 1 to 45, and bleeding to the point of exsanguination is the leading cause of preventable mortality in that population. So anything we can do to impact that population and improve outcomes would be welcome, and we have identified an opportunity actually, that could save, again, thousands of lives. We have an expert panel to talk about this issue gathered here today. I'm going to give them an opportunity to introduce themselves, and then we'll get into the discussion. We'll begin with Dr. Holcomb, Dr. John Holcomb.
Yeah, so my name is John Holcomb. Hello, everybody. I'm a general and trauma surgeon. I work for Dr. Kirby. He's my boss.
With.
He always says with, and I say for. That's what you're supposed to say. Yeah, I was in the Army for 23 years, retired a long time ago. Spent a lot of time working on blood and resuscitation, stopping bleeding first, and then filling the tank back up with blood. It's a pretty easy concept, and it's one that we need in the military have adopted, and Colonel Gurney will talk about that. But in the civilian world, less so, and we'll get into those later on in the press conference.
Right, Dr. Holcomb. Dr. Peter Fisher, who's chair of our EMS committee for the Committee on Trauma.
Yeah, Peter Fisher. I'm a EMS physician and trauma surgeon from Memphis, Tennessee. I chair the EMS committee for the Committee on Trauma. Former firefighter, paramedic, and still fly today in the back of a helicopter at times. Don't worry, I don't actually touch the controls. They don't let me do that. But again, as Dr. Holcomb said, this is a great opportunity, and we really need to take down some of the barriers that some of our EMS agencies are facing to get this life-saving intervention into the field. The patients get injured in the field. Let's start care in the field. And let's take down some of the barriers that we have so that really we can provide this life-saving resource at the point of injury and start it as early as possible.
And Colonel Jennifer Gurney, who's the chair of the Joint Trauma System.
Yes, thank you. I really appreciate the opportunity to speak on behalf of the military's perspective. My name's Jennifer Gurney. I'm a colonel in the United States Army. I'm a surgeon, and I'm here to share some of the lessons learned from the military and how we can use those lessons learned to improve civilian trauma lives as well. We had some barriers to implementation of pre-hospital blood, but once we were able to implement it, it's something that moving that capability closer to the point of injury has made a huge impact on lives saved on the battlefield. And I look forward to your questions.
And finally, Dr. Mike Pearson, who's the chair of our Rural Trauma Committee for the Committee on Trauma, to speak from the rural perspective.
Thank you, Dr. Kirby. I'm Mike Pearson. I'm a general and trauma surgeon from Sioux Falls, South Dakota, and I'm representing the rural aspect and the disparities of care that really occur from the length of time and the length of identification, how important it is that we initiate care in the field because the identification time for patients is so much longer than it is in the urban center, and how this can really save lives. Great. Thanks, Dr. Kirby.
Absolutely. We'll start with Dr. Holcomb. Dr. Holcomb, what is the opportunity here for uniform access to pre-hospital blood?
Yeah, so number one, I'm going to start off with the bad news. Right? The bad news is that only about 1% of EMS vehicles, whether it's ground or air, carry blood in the United States. 1 to 2%. So the vast majority don't. This pre-hospital blood that we're talking about, there's no need to do more studies. The data are very clear. It absolutely saves lives. Prospective randomized level 1 data, pre-hospital blood saves lives. 1 to 2% of EMS agencies carry blood. Only about 1% of patients who could receive blood every day in the United States. I tell everybody, I don't know if San Francisco, they have blood, but there's many cities that we all work in that don't. You should drive very carefully in those cities, right? Maybe a little bit less careful in the cities that do have blood, but in the ones who don't, which is 99% of the United States, be very careful, because your risk of death is higher in those places that don't have blood than it is in those that do. The numbers are staggering. Trauma is the leading cause of potentially of death in the United States. Hemorrhage is leading to death, is the leading cause of potentially preventable death. And the best estimate that we have right now is probably 10,000 lives a year could be saved if every ambulance in the United States had blood. Now that's a big ask, right? And we'll get into those numbers as well. And from motor vehicle crashes about 5,000 lives, about half of that. So there's not many things that you can do, that we can do as a community, that are already FDA cleared, that are already proven, that will save 10,000 lives in the United States, except putting blood everywhere.
Yeah, so the potential is there to save a large number of lives. We know that. That's been proven. What are let me ask Dr. Fisher, what are the barriers to having more access to pre-hospital blood and having these on ambulances?
Yeah, the EMS professionals are ready. As always, our EMS professionals have stood up and said, we want the best thing for our patient, and we're ready to do this. We need some training, and the entire community is there and ready to do that training. I think there's a couple really big barriers that we're facing right now. In some states, actually, EMS professionals aren't allowed to initiate blood in the field. So we need to fix the scope of practice issues that we see throughout the United States. The other one that's really a profound one is the reimbursement cost. EMS and emergency care provided in the field reimbursement is still really based on transportation only and not necessarily the care that's given. And we really need to switch that paradigm such that we really can get reimbursed for this life-saving issue and keep the EMS agencies, keep the lights on for the EMS agencies. As Dr. Holcomb said, it's only 1 to 2% right now. That's about 175 ground crews over the United States, and a lot of them are doing that at their own cost. It's not cost neutral. They're doing it at their own cost, which is fantastic for them. But again, as Dr. Pearson will, I'm sure, will point out, it's in the rural communities, 50% of these EMS agencies are volunteer. And the volunteer agencies do not have the resources to be able to flip the bill on this on their own.
Mm-hmm. Yeah. So maybe Dr. Gurney, the military does inform the civilian practice and vice versa. What have we learned from the military experience with pushing blood far forward in those environments and the impact it has had on saving lives?
So it is the transfusion practices are one of the best examples of the reciprocity between military and civilian trauma systems and how we can learn from each other. We started fielding pre-hospital blood in 2012, getting it out on helicopters, and moved to using whole blood pre-hospital. And the initial study that came out in 2017 demonstrated a 4-fold increase in survival in the first 24 hours. So 4-fold increase in survival. And that survival was also for 30 days. So it increased 30-day mortality as well, or decreased 30-day mortality by 3-fold. So huge life-saving capability. We're lucky that we have a blood program. The Armed Services Blood Program fields the blood to the contingency or operational environments. And so we have our own system that we can get blood from, and it's a big logistical challenge to be able to get blood far forward on all the helicopters downrange. But it's something that, when it was recognized, the massive impact that it had to save lives of exsanguinating casualties, it was a big investment. And we don't have even our conventional and our special operations forces do not go out on missions downrange without blood. It's a checkbox. They must have blood, and we transfuse that blood pre-hospital. We use low titer O whole blood, but the initial study was with component therapy. But the point is, you need to give blood close to the point of injury as soon as possible. The study that we did, it was within 36 minutes. So blood 36 minutes after injury had a 4-fold increase in 24-hour survivability. That's a big deal. And so when we saw that, it was a massive investment on the military standpoint, medical and operational units to ensure that every team that went out on mission had a blood capability.
And Dr. Gurney, you also have the perspective of actually working in a civilian practice where the community has a whole blood program. Can you sort of speak to the
San Antonio
impact
is one of the, so I'm in San Antonio, it's one of the best examples of a military-civilian partnership. It really is an integrated trauma system in San Antonio. And a lot of the leaders in blood, like Dr. Don Jenkins is at UTSA, and they have, taken those military lessons learned and regionalize them in San Antonio. So we use whole blood pre-hospital, and there's a constant monitoring of what rigs have whole blood on them, and so that's a great example of military lessons learned being implemented in a civilian trauma system. And it took civilian leadership to get that done, and people like Dr. Jenkins, Dr. Brian Eastridge made a huge difference in getting that implemented in our community.
Dr. Pearson, so 30 to 40 million Americans live more than an hour away from a major trauma center. And we know that outcomes in rural environments are worse. So there's a disparity in outcomes between rural and urban environments. And can you speak to the amount of time it takes to get to a trauma center, maybe what the impact of blood would have on that window of survivability for those patients that are injured and bleeding after traumatic injury?
Yeah, just to highlight, Dr. Holcomb made the comment that only 1% of EMS carries blood. Well, that's not rural, 1%. So we're down to almost zero. So the only way you're going to get pre-hospital blood is going to be possibly in air flight, which is challenging if you live in a rural community that doesn't always work that way. The disparity here is really what you have to focus on. If you think of all the motor vehicle crashes, 50% of all motor vehicle crashes occur in a rural area, not an urban area. They occur in a rural area. And if you think that only populates, or the only population there is 19% of all of the U.S. lives in a rural area, but the disparity is that 50% of the crashes occur there. When it comes to transfer time, so pre-hospital transfer time or pre-hospital identification time is over double in a rural setting, and most people would argue it's probably tripled or quadruple. So if you got injured here and it took you 10 minutes to get to the hospital, it'll take you an hour. And if we talk about a majority, 30 to 40% of trauma patients are found alive but then die, it's potentially in an MVC, you can really see that potential intervene is immediately important. And I like to think of the rural environment similar to somewhat as the military environment, where it's a more forward station. There's multiple steps to get me to where I need to go. And we have to move that blood to where the people are. The problem is where the people are. It's not at the hospital. So we really need to push that forward to get it where it's needed, and that's in the field, which is very challenging logistically because of the disparity of being in a rural setting.
Yeah.
Dr. Thinking about this in the rural setting, what the military has is we have these, in the deployed environment, we have blood support detachments. This is a constant recirculating blood, the cold chain storage. I mean, it is not an easy logistical lift. However, if we can do it in very austere, areas that don't have capabilities that even rural trauma systems do, then it should be something that should be done in the rural trauma system.
Yeah. Dr. Fisher, I want to lean into something you said earlier about EMS, and I'll say EMS partners. Our EMS partners are really our partners in the care chain of taking care of our trauma patients, but they're only reimbursed for the transport they provide, even though we know that they can provide life-saving treatment on the way to the hospital. Can you talk about that a little bit and what some of the challenges there are there for our EMS colleagues?
EMS, if you think about emergency medical services in the United States, it's a relatively new thing. I mean, doctors have been around for a long time. EMS, professional EMS as we know it, has been around probably for 60 to 70 years at best. So we're still going through lessons learned and constantly evolving. The EMS is based in the National Highway Traffic Safety Administration, and really at this point was really started as a transport agency. What we really have to do to continue to impact those injured patients is move it from a transport agency to a true care agency, no matter how that patient gets transported. and be able to get reimbursed then for the interventions that the EMS provides on the field. Again, EMS is ready for this. They've been ready for this. They're excited about this. It's really just catching up the reimbursement. As Dr. Gurney said, there's a lot of logistics to this. It's the storage, it's the administration, it's the training. Really up to, if you put all those things together, you're probably talking about $1,000 to $1,500 per unit infused. That EMS agency may only get reimbursed for that, $800 for that entire transport. So it's very difficult. How are they going to sustain themselves getting reimbursed $800 for a transport, but they use 2 units of blood and they have to pay their people? So that transport costs them $3,000, $4,000.
Yeah, but as logistically difficult as it is, there are models out there in our communities where it's been very successful. So we can do this. Dr. Holcomb, you want to speak to the opportunity there?
Yeah, so the models, the logistics are somewhat local. The logistics in Arkansas are going to be very different than the logistics in Memphis, Tennessee, right? But the opportunity to care for that individual patient who suffers hemorrhagic shock, who is bleeding to death with blood is the same. It's the same. If you think about for the old people in the room, if you have a cardiac arrest right now, you expect the medics to come up and shock you and defibrillate you and do all that kind of stuff like on TV, right? That's what they do. But if you're bleeding to death, they don't have blood. 99% of them don't have blood. And yet it is the leading cause of death of age 1 to 50 in the United States. So for the majority of the people in our room, the EMS guys can do the heart thing to you, but you don't have that problem because the majority of the people in this room are in the less than 50, and you're going to die unless EMS comes up and gives you blood. Now, what they do have is the clear stuff, the crystalloid, right? The saline, the clear bags that are hanging in. It costs 90 cents. They have that, and they'll give that to you. That actually, if you're bleeding, increases your death. So the thing that they do have on every ambulance, if you're bleeding to death, increases death. And they don't have the thing that we know saves lives on their rigs. The disparity is huge. There's a disparity as the colleagues have said, in the EMS agencies that can afford to eat the cost of 1,000 units of each bag, right? And so who has blood? Places that have, what EMS agencies have blood? They're in centers and EMS agencies that can afford this because they're well funded. But the majority of EMS agencies are not, whether they're in South Dakota. I live as much as possible outside of a little town called Burton, Texas, population 297. Right? I live outside of that town. Talk about rural, right? Talk about rural.
Do you carry blood with you in your car?
Yeah, I drive very carefully. I drive very carefully. The disparities are very real. They're based upon lots of factors, but the bottom line is, as we said, very few EMSAs have this proven capability, and cost is one of the biggest deals. And if I can just keep going for just a second longer, we have, as a group over the last decade, figured out how to do this and figure out how to do it safely and to meet all of the rules with blood. Keep it cold, keep it at the right temperature, warm it up, give it all those rules, just like we do in the hospital, have been done pre-hospital, both on ground and air in different places in the country.
Yeah, I saw some data from, I think it was National Highway Traffic Safety Administration, 42,000 plus motor vehicle deaths per year. 18,000 of those deaths were alive when pre-hospital providers got to the scene to initiate care. So a huge opportunity there and most of those would have died from bleeding, from exsanguination, blood loss. So huge opportunity. So we have this life-saving treatment. We have professionals, partners in the care continuum, the EMS professionals that can provide this treatment. What's it going to take to get this across the finish line? How can we improve access of those injured to this life-saving product? I'll open it up to
The logistical
anybody.
challenges have been solved, right? We've seen that. There are some EMS agencies out there that are doing an amazing job with this. And the best part is that none of them want this proprietary. They're willing to share their information. They want to share this. They want to get this out, which again shows to just how important it is to everyone. So those challenges are there. We've got to find a way to make it cost neutral and to make it so that the EMS agencies don't have to take a hit on this when they give this life-saving treatment. And then we've got to work through some of these scope of practice issues that we've seen. Again, as everyone has stated, the data is there. We've got a little bit of convincing to do to some that just really don't believe the data yet. But I think, again, that can be done and those logistical challenges can be overcome.
John?
Yeah, so what needs to be done is, we're doing it right now. You guys are listening. We're going to have questions. This is a little bit of a public relations campaign. It's a policy campaign. Congress needs to add money to CMS's budget so that they can pay, reimburse, and that's just the way healthcare works in the United States. And then once CMS does this, and they're partners and they're listening and they're doing their part, but money needs to be added to their budget. And once that happens, then private insurance will follow. Again, healthcare economics in the United States, that's the way it works, and it starts with this kind of effort that the college has helped lead.
Yeah, certainly recognizing EMS as an essential service, which is not recognized as in a lot of states across the U.S., would help, as well as changing the reimbursement paradigm from transport to the interventions that they provide. I want to open it up to questions from the audience. Dan, do you have anybody online or anybody here have questions?
Yes, we have NBC Colorado Springs is watching, and they have a whole blood program there in Colorado Springs. So how might that go national, whether it's Colorado Springs, San Antonio? What are the lessons learned from that of how this can be in other communities around the country?
Again, I think that, it's all politics are local, all logistics are local. And again, what works in Colorado Springs, we can take lessons from that and apply it to other metro areas. The amount of information sharing that's gone on with this has been fantastic. People that have pulled this off and are doing well with this are, again, very willing to share their information. And it's lessons learned from all of these areas. I think Dr. Pearson can probably talk to it. It's going to be even more challenging in some of the really rural environments. But Montana has done some amazing programs in that, and that's a very rural state. So again, all of these things can be overcome. We just have to continue to work together. And I think, it's events like this that raise awareness, and, it's the population that's going to come up and say to their legislatures, hey, we want this. We need this. I don't want my loved one to die from a potentially preventable injury. How can we do this? How can I actually get this in my local center? And I don't think that the public is aware. I think the public assumes most of the time that the ambulance is carrying blood. And that's not the case. And it's educational events like this that can help that.
Fantastic. Any questions from the audience? Sir.
Good morning. Crisanto Torres, trauma surgeon at Boston University, Boston Medical Center. Great to see you again, Dr. Holcomb. So in the state of Massachusetts, we have a problem. And one of those problems is that our ground EMS agencies are not allowed to transfuse any type of blood product. About a year ago now, BMC partnered with Kenton Fire to develop a special project waiver to get this approved. And I can tell you we fought tooth and nail and continue to fight tooth and nail to expand this program. And what we do, we give, pre-hospital whole blood. I can say we save lives, but again, it's just a special project waiver, and it's only those 25 towns and cities south of the Boston metropolitan region, in which there, is a lot of disparities in health outcomes and issues like that. What can you speak to individuals such as people in my scenario where we have the evidence, we're trying to reach out to the EMS physicians to act on almost common sense that if you're bleeding blood, you should get blood and not no more saline. Because every time I look at an EMS run report of an individual who comes in, I always say that person could have survived if they got some type of blood product and not no more saline.
The hardest thing to change is tradition.
Culture.
That is the hardest thing to change. The data are there. There are more data being generated every day. People who spend their whole lives figuring out how to change tradition and change practice. The medical world is not immune to that change in tradition and practice. And all I can say is, It's worth it. Put your head down, keep working, and you'll get there. I mean, I have no magic answer for you. Everybody is sharing these lessons learned. And by the way, I know we're being, as the American College of Surgeons and the Committee on Trauma,
Right.
but half the blood, once you have a program that does this, half the blood or more than half the blood is given to non-trauma patients. Postpartum hemorrhage, ectopic bleeding, GI bleeding. I mean, other reasons why people go into what's called hemorrhagic shock, bleeding to death, half of the blood is given to non-trauma patients. So there are, it's not just trauma out there, but I feel that your angst, I feel your pain, it's worth it, keep working on it.
And the scope of practice issues can be fixed. And we've done this before. I mean, when we started Stop the Bleed, for example, we were teaching civilians how to pack wounds. But in some states, paramedics and EMTs weren't allowed to pack wounds because it was out of their scope of practice. And we've worked really hard to fix that. We have the infrastructure to fix it. And again, with awareness, we can fix these scope of practice issues working together.
Great. We have a question over here.
Good morning. My name is Mark Crow, physician in California. Thank you. And actually sit on the state's TMS commission. And the good news is that in California, there is currently a project being implemented in Southern California involving about 45% of the state's population for pre-hospital blood transfusion. One of the barriers that we have here is that in the state of California, EMS is delivered often by a mixture of public service agencies such as fire departments and a very, very large proportion of private for-profit corporations who are very hesitant to add costs that are not reimbursed. How has that been addressed in jurisdictions that have successfully implemented a program that have involved a private contractor?
I think, in all honesty, right now, a lot of the EMS agencies that are giving blood are taking it as a loss. And that, in all honesty, is the truth. And I think that's why we've seen really more adaptation of pre-hospital blood in the kind of the civic run or the city or the county run organizations as opposed to the private organizations. We really want to thank CMS for putting it in the 2025 physician fee schedule, which adding blood transfusion as an ALS2 code, which will help solve some of these reimbursement issues. It's not going to be enough. It's not enough yet for an agency to say, well, I don't have a program now, so with this now I can start a program. There's certainly, the reimbursement isn't quite there, but at least it's a great step. And it's recognition by CMS that this is a life-saving intervention that can be pushed down. And again, like you said, they are for-profit companies, so we have to make sure that they're not, that they're able to provide this essential service, but without losing money on it.
The other thing is, we've talked about blood and whole blood. Whole blood is expensive. Plasma is much cheaper. It's 1/10 the cost. So there are ways to start your program that are cheaper. You hate to say cheaper when we're talking about saving lives, but that is the reality of healthcare in the United States, right? It is worth the healthcare economists, the people who really study this, look at not the silo of pre-hospital and hospital, they look at healthcare. And it is a healthcare saving. We save money by saving lives, right? But we work in these silos, and we work in pre-hospital is one silo and hospital's another. If your EMS agency belongs to the hospital, it's no problem. It's no problem, right? But most of them don't.
We have a couple of other questions online.
Yes, we have a few more questions from the live stream. The first one is about that finance is part of this, but what about the supply chain of blood? How does that factor in?
Yeah, good question.
Yeah.
All right.
Yeah, go ahead.
Dr. Pearson, why don't you take that?
You repeat the question?
Supply chain.
Bill. So I think supply chain is a challenge. When you talk about, as Dr. Gurney brought up, circulating that blood and supply chain through a rural facility, a rural area is a very big challenge, not insurmountable, but clearly, there needs to be some thinking outside the box, and you really need to start with the framework of going where it works well, disseminating it in larger areas, and then working it down through the other areas to build a strong infrastructure. At least that would be mine. I don't know if Dr. Gurney has an opinion on supply and infrastructure.
Well, the advantage that the military has is that we're one system. We're not, there's not multiple EMS systems, competing or, with that have some that finances play a role. One integrated system where that blood can circulate between the hospital and the pre-hospital environment and the expiration dates being monitored, that takes a lot of coordination. I mean, it's not something that you can just do without really having an integrated trauma system. And I think it's harder on the civilian side because there's multiple EMS agencies. Like you were just saying, some volunteer, some fee for service. And so that makes it much harder. In the military, you know, it's the military, right? So it's, you say, this is how we're going to do it, and we can create a standard, and people have to, you know, to comply with that standard. So I think it's, that part of it is harder, but even the logistical part for us, think about, you know, our blood originates in the United States at the Armed Services Blood Program donor centers, gets shipped overseas, shows up at one of the hubs overseas, and then gets distributed to the forward operating bases, all that with a cold chain. It has to stay temperature regulated. And we're limited by flights and limited by rotary rings. So it's hard. It's a logistical balance, but we've dedicated resources to ensure that there'll be blood at these forward operating bases and for when the medics go out on mission. I mean, it's an issue, and it should really never happen in the deployed environment for medics to go out on mission without blood now. It is a standard for us because it saves lives. And so, and does it come at a cost? Yes. Do we waste blood in the military? Yes, we hate it, but we do. But that's the cost of saving lives. And so that's the investment, and it's probably, because there's more finances involved on the civilian sector, it's probably a harder investment to make. But for us, it's a no-brainer at this point.
We really want this to be a trauma system initiative, right? This isn't an EMS initiative. This is a trauma system initiative, and this should be your local trauma system initiative to work out these logistics. So ideally, you aren't wasting blood, that you're able to move these units around to ensure that there is no waste. And yeah, a great example of San Antonio.
And that's really the importance of an inclusive trauma system, right? This really boils down to how do you develop a large, inclusive, nationwide trauma system to develop and move this around. This is just one example of how bringing that portion to light is huge, because my guess is if we really queried the general public and say, hey, you know, if you got hurt, what would happen? Oh, this is an amazing thing would happen, and we just go to wherever I need to go. And there's a lot going into that, and it doesn't always work as well as we'd like it to. And I think really pushing, especially from a rural perspective, the inclusive trauma system that has this almost military mirrored stepwise process is really where we're driving to. And this is just a prime example of why we need to do that.
Yeah, the supply chain is a really interesting question, right? So blood is a precious commodity. What we've done with many partners is kind of said, you know, we're probably going to need about 90,000 more units of blood if we're going to put blood on most of the ambulances and helicopters in the United States. The blood suppliers would have a hard time meeting that today. They'll eventually get there because I have great confidence in them to generate more donors from a supply chain, many ways to do that, and then distribute blood equitably across the country to relieve kind of these blood deserts that we have in the United States today, where there are many places, Arkansas being one of them, that has this prohibition on medics starting blood. By the way, I'm from Arkansas, so I can say that. And the supply chain moves all the way through, right? We're moving blood around, like the panelists have said. There's also bags. I mean, there are so many things with this supply chain problem, the supply chain issue that are out there. They also apply to crystalloid, by the way, which there's a crystalloid shortage in the United States. I don't know if you guys knew that. That's actually a good thing for the bleeding patients, that there's a crystalloid shortage.
Right. Dan, another question?
Yes, we have a question about what changes need to be made to the paramedic curriculum to reach this goal, and also are blood suppliers on board with this?
Certainly there needs to be training behind everything that we do. In all actuality, though, giving a unit of blood is not much different than giving a liter of crystalloid, which all paramedics and EMS professionals are trained to do. So it's not a huge training lift that needs to happen. It's really, at this point, I think the biggest challenge is actually getting it in their hands. Once it's in their hands, we can train around it. But getting it that first step is getting it in their hands, and that's our overall goal.
Yes. Any other? So so we have a lot of partners in this crusade that we're on, right, to save lives, and we have the Pre-Hospital Blood Transfusion Initiative Coalition. We've got the American College of Emergency Physicians, National Association of EMTs, National Association of EMS Providers. There's a lot of people that believe in this message and the impact that pre-hospital blood could have. For those who are listening to this and wondering what they can do, what is really the call to action to really help increase the access to pre-hospital whole blood? What can people out there do?
So I think we'll all have everybody on here needs to answer that question because we'll all have a little bit. Number one, go donate blood. Right, go donate. If you don't donate, you need to donate because the blood suppliers need more blood to give to EMS agencies so that they can give it to patients. And in the meantime, you should all go home, call your local EMS agency that covers your house and ask them if they have blood. If they don't, why not? They'll tell you some of the reasons we've talked about, and then talk to your local congressman and senator, right? Because CMS needs more money to put money into the budget so they can pay for it.
Yeah, ask questions, be inquisitive, go out and find out what those barriers are at your local level. Because again, they're all going to be different. They're going to be all the same and they're all going to be different all at the same time. And then once you find out those barriers, please reach out. There are resources throughout the United States. The American College of Surgeons has resources. We'll help you. We want to help you. We want to know what the barriers are so that we can help fix it for somebody else. So please, reach out when you find out what those barriers are, and hopefully we can have the resources to help you get through them.
Since Dr. Holcomb said everyone had to answer, so I would say collaborate and share lessons learned. And an example of that, and many of us were at the San Antonio, the STRAC Whole Blood Summit that happens every year. A bunch of EMS organizations were presenting their success stories and their barriers. And so learning from other systems, because like Dr. Holcomb said, and like your first question, every system's different. Every system's going to have things that are easy, and every system's going to have things that are hard. And so collaborating, sharing lessons learned, whether it's administrative or at leadership or at policy levels, that's the way to eventually get to this national integrated trauma system, which we need for blood and we need for other reasons too. And so I think that would be my answer.
Dr. Pearson, final comments?
Well, I guess I could say they took all the good ones. I would say you need a story. Story is what you need, and that's how you move people, because you do need to talk to your regional legislators. You need to talk to your local EMS. You need to support them. But then you need a story to tell behind it, because that's how you move people. So you find that trauma victim who's been saved by blood and good care and the EMS, and you post that everywhere like it's nobody's business. And that story is the story that moves people. And I think if I could tell you to do one thing, that's what you have to do. You got to find the story, you got to find the support, you got to find the public, and they got to back the move. And that's how we move this forward.
Yeah, advocacy is so very important to affect change, real change. So advocacy is one of the keys to this. Well, I'd like to thank the American College of Surgeons for this opportunity to have this panel. I'd like to thank our expert panelists for their time, those in the audience for their interest, and online. Thank you so much for your interest, and we'll close now. Thank you so very much.
He didn't do anything. I was really waiting for you to say that.